Welcome everyone to our session titled Decision Making and Professional Accountability, a Roadmap for Navigating Dilemmas in Practice. My name is Annette Johns and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I will be co-moderating the panel this afternoon along with my colleague Peggy Rauman, Nursing Consultant, Policy and Practice with the College of Registered Nurses, Newfoundland and Labrador. This year marks the 17th anniversary of our collaboration to host this annual education event for healthcare professionals. The topics have been quite diverse over the years, and I look forward to our continuing partnerships in organizing this event on a yearly basis. Today's session is being offered on-site from the Health Sciences Main Auditorium and by live webcast. While this event is organized by the NLASW and CRNNL, we would like to acknowledge the College of Licensed Practical Nurses, Newfoundland and Labrador, who have partnered with us to bring this education to you today. We would also like to thank the MUN School of Nursing for their support, and to the staff from the Center for Innovation, Teaching and Learning with MUN, who are here with us today and broadcasting this event in real time. This session is being video recorded and will be made available on the websites of our professional associations for future viewing. We do have a tight schedule for today's session. We'll begin with a presentation from each of our panelists, which will be followed by a discussion on several case scenarios. There will be an opportunity for clarifying questions. However, we do ask that you keep your questions succinct and with the understanding that the session is being recorded. For those attending by webinar, please email your questions to educationwebcast2020@gmail.com. We will have microphones in the room for those who ask questions during the designated question period. As healthcare professionals, we make multiple decisions every day, sometimes in the midst of competing demands from clients, colleagues, or employers. Some decisions we make in the moment, while others require reflection and consultation. Yet what is it that informs our decision-making? This is a very important question to reflect on. Is it practice wisdom, a reflection on our code of ethics and standards of practice, consideration of legal or legislative issues, a review of organizational policies, or consultation with colleagues? All of these elements are extremely important, and for the purpose of today's session, we want to provide a framework that healthcare professionals can use to guide decision-making, particularly when there are complex ethical or practice decisions that need to be made. We encourage you to think about the material presented within the context of your practice, and we hope the dialogue continues amongst colleagues and teams following this session. We have 5 stellar panelists joining us for the presentation today, and each brings tremendous knowledge and expertise on the topic. They will highlight the areas that need to be considered when making ethical and practice decisions in our work. So I now want to take a moment to introduce our panelists. So first we have Michelle Osman, to my immediate left. Michelle joined the College of Registered Nurses in 2008, following 21 years of practice as both a staff nurse and clinical nurse specialist, primarily in long-term care nursing. As the Director of Regulatory Services, her primary responsibility includes providing direction and leadership on the processes that govern registration and licensure of RNs and NPs in the province. In her role, she is also appointed by Council as the Director of Professional Conduct Review. Michelle notes that this is a challenging aspect of her role, requiring daily administration and management of various aspects of the PCR process, in accordance with the Registered Nurses Act of 2008. In her position, she has frequent interactions with RNs and NPs, council, and other stakeholders as she provides consultation and information related to regulation. Next, we have Jerry Smith. Jerry is a lawyer with the Provincial Department of Health and Community Services. As its legislative consultant, she is responsible for over 80 acts and regulations which fall under the department's mandate. Jerry works closely with health profession regulatory authorities in the province to ensure that their legislation is up to date, modern, and reflects changes to the professions. Jerry is a member of the Law Society of Newfoundland and Labrador and has been practicing law for 22 years. For the past 15, she has practiced exclusively within the area of health law. Jerry completed her legal studies in French at both the University of Moncton in New Brunswick and Laval University in Quebec City. She is currently completing a master's degree in health law through Asdale Hall Law School in Toronto. On a personal note, Jerry balances her busy legal practice with being a hockey mom, of which I am as well, to 2 boys. And when she's not freezing at the hockey rink, which I frequently do, Jerry is an avid reader and committed volunteer in her church community.
Attention all personnel, the code red system is now back in service. Please resume normal operations. Attention all personnel, the code red system is now back in service. Please resume normal operations.
A member of the Halapu Mi'kmaq First Nation Band, Jerry is originally from the town of Lourdes on the Port au Port Peninsula. Next, we have Simone Pilley. Simone is a registered social worker who works in private practice in Gander. For 20 years, she's worked with children, families, and adults in the field of mental health and wellness in New Brunswick and here in Newfoundland and Labrador. Simone is a diplomat and certified member of the Academy of Cognitive Therapy. This certification is awarded to mental health professionals who have demonstrated an advanced level of expertise in cognitive behavioral therapy. Simone is chair of the NLASW Ethics Committee and a member of our Connecting Voices editorial committee as well. Next, we have Chris Kapowski. Chris is an associate professor of bioethics at the Faculty of Medicine, Memorial University. He is also a clinical ethics with the Provincial Health Ethics Network of Newfoundland and Labrador. He teaches in the Master of Health Ethics program and the Doctor of Medicine program at Memorial. Chris is also editor of the Canadian bioethics blog, Impact Ethics, which is hosted by Memorial Centre for Bioethics. And last but not least, we have Molly Butler. Molly is a registered nurse and the regional director of professional practice and Indigenous health with Eastern Health. After living away from the province, Molly returned in 2011 to take on the role of professional practice nursing director with Eastern Health. In 2014, her role expanded to include 10 other professions, and in 2016, she agreed to add Indigenous health to her portfolio. Molly has worked in 4 Canadian provinces as well as internationally. Her professional grounding is nursing, and she has a Master in Public Health Administration from the University of Victoria. And while living abroad, Molly completed her Doctor of Philosophy in Higher Education through the University of Stellenbosch in South Africa with a focus on professional development. Molly's professional experiences includes clinical, management, and professional governance. So what a wonderful panel. I'm sure I haven't done you each justice by that quick introduction, but I do want to welcome you here for our education event today, and I'll invite Michelle forward to begin the panel presentation.
Thank you, Annette, and I'm glad to be here this afternoon to speak with you and to bring you some regulatory perspectives on our topic here this afternoon. Just going to advance. Okay, good. Self-regulated professionals, including registered nurses, social workers, and licensed practical nurses, are accountable to the public, their clients, regulatory bodies, and employers to provide safe, competent, and ethical care. Professionals act, first and foremost, in the best interest of their clients and the public. Public trust in a profession is supported and maintained when these basic principles are applied by professionals in their client care and service. Decision-making for regulated professionals will be guided by the directions and expectations set out by the profession in the standards of practice and the code of ethics. These regulatory tools are foundational to each profession and provide the legal reference for reasonable and prudent practice. The principles and values in the standards and code provide professionals guidance about the knowledge, skills, abilities, judgments, and attitudes that should be applied in practice. Each professional is responsible for understanding the standards of practice and the code of ethics and applying them. This includes applying them in decision-making. The standards of practice and code of ethics are used in conjunction with other relevant documents approved by a regulatory body, including policies, guidelines, and other supporting resources that will provide additional clarification on certain areas of practice. An example includes regulatory documents related to medical assistance in dying, and each of the regulatory bodies participating in the presentation today have approved documents related to MAID. It is important for practitioners to be aware of other regulatory documents approved by their respective regulators, and these documents not only reflect current and emerging areas in practice, but also guide practitioners in core areas. And examples in the nursing profession for core areas would include documents related to medication administration and therapeutic client relationship. As practice evolves, regulatory documents will be revised from time to time to reflect new knowledge and evidence, new or changing legislation, and other factors. Technology is an example of one factor which impacts practice. It is bringing changes to practice in the area of client access to services. An example of this would be telehealth. Social media, also related to technology, is another example. Regulatory bodies have been addressing this area in guidance documents in recent years. Other resources that a regulator professional will use in decision-making include specialty standards, clinical practice guidelines, accessing clinical experts and consultation with interdisciplinary team members, relevant legislation, and employer policy. Practice situations that present ethical questions may require an ethical consultation to inform decisions. My co-panelists this afternoon will elaborate on considerations related to these areas in their presentation. As you are presented with decision-making in your practice, use tools available from your regulatory body to guide you. Apply the standards of practice and the code of ethics as you plan your actions. As a regulated professional, this is a requirement. Adhering to the standards, of course, and the code is a must-do. Reach out to your regulatory body if you have questions related to applying the standards and the code in your practice. Discussion with a practice consultant can assist in clarifying aspects of the situation for your reflection. So, some takeaways. Ensure your decision-making is in the best interest of your client and that your actions demonstrate accountability, and broadly include the following areas. And I've put some questions for your reflection for each of those areas. So, self-assessment. Do you have the necessary skills, ability, and judgment to inform your decisions? Resources and assistance. What other resources, including regulatory documents or guidelines, are available to guide your decision-making? Would consultation or collaboration with a team member assist you, or a clinical expert? Is your decision-making evidence-informed? Is it based on evidence or the best available evidence? Documentation, and this is critical, of course, as a regulated professional. Have you documented your decision-making and related information, like the outcomes? And remember, documentation is a demonstration of accountability. And in conclusion, review and reflection. Professional practice is a reflective process. Review the outcome in relation to the standards and the code. What learning did you take from the situation? What areas do you need to seek more information to prepare for similar situations in the future? And through the situation, you may identify a future learning goal that you would include in your continuing competency plan. Those are my comments on some regulatory perspectives. Thank you.
Thank you, Michelle. That was excellent. I'll now invite Jerry to the podium.
Good afternoon, everyone. I'm here to talk to you about the law as it pertains to your professional decision-making. Annette and Peggy have given me 5 to 7 minutes, which is why I have my cell phone. I promise I won't take any calls or answer any texts from my kids. But as you can appreciate, talking to you about the law in 5 to 7 minutes, we will only be scratching the very surface. So my purpose is to just give you some of the highlights, and if you have any questions with respect to your legal obligations, at least you'll have some indication of where to go to start. So we do need to start with the sources of law. So this pyramid illustrates the 3 sources of law in Canada. So we start with the constitutional law. That's at the peak of the pyramid. And what that covers is there's 2 aspects to the Constitution. It sets out what authority each of the provincial governments and the federal government have with respect to the authority to make law. And it also refers to the Charter of Rights and Freedoms, which I'm sure we're all familiar with. But in terms of the first aspect, so for example, in the Constitution, it sets out specifically that if we're talking about ferries between provinces, then that falls under the federal jurisdiction. So Marine Atlantic, for example, would be a federal responsibility. However, the ferry between the province, the island of Newfoundland and Bell Island, is within a province, and the Constitution affords responsibility to the province for that particular ferry. So there is a delineation within the Constitution when it comes to lawmaking authority, whether it's federal or it's provincial. So underneath the Constitution, we have statute. So statutes are the laws that are either proclaimed and passed by the provincial legislatures, so our House of Assembly here, or the federal Parliament. And again, it depends on which area, who has authority to pass laws in a particular area. The significance of the pyramid is that statutes fall under the Constitution. So Constitution is paramount, and statutes have to comply with the Constitution. If they don't, then they're at risk of being struck down and voided. While this pyramid doesn't talk about regulations, regulations are also law which fall under statute and are based on the authority set out in a particular statute. But like I said, they're also law. Underneath that is common law. And common law refers to simply as judge-made law. So it could be court decisions whereby a court interprets a particular statute, or it could be decisions in areas where legislation doesn't exist. And I'll talk to you a little bit more about that in my presentation. But again, looking at the pyramid, the top is the Constitution, statute, then common law. So as you work your way up, the common law must be consistent with statute, or must comply with statutes, and statutes must comply with Constitution. So let's just take a moment then to talk about provincial legislation. So as a healthcare professional, there are multiple pieces of legislation that would apply to you in your decision-making as you practice your profession every day. Given I only had a few minutes, I couldn't go through all of the possible statutes that may apply, but I've highlighted a few examples. So the first one, Advanced Healthcare Directives Act, that pertains to consent in terms of who can consent to healthcare decisions, the concept of substitute decision makers when a person is not capable of consenting to healthcare decisions. The Children, Youth and Families Act, which sets out a duty to report for healthcare professionals where there's information to believe that a child is in need of protective intervention. The Patient Safety Act refers to primarily to those healthcare professionals who are working within an RHA setting, and it pertains to occurrences and adverse health events and what your obligations are with respect to those. Personal Health Information Act is our privacy legislation in the province that pertains within the healthcare system, so personal health information, and it sets out the obligations of custodians and employees of custodians with respect to the collection, use, and disclosure of personal health information. The other one I have there is one of the most recent pieces of legislation in the health field is the Public Health Protection and Promotion Act. And in that particular act, there is a duty to report for healthcare professionals with respect to communicable diseases. So that's just to highlight some examples. And then, of course, if you're a member of a regulated health profession, then you would be also interested in the statute which governs your particular profession. So right now in the province, we have 17 health profession statutes, but 23 regulated health professions. And of course, the social workers, registered nurses, and licensed practical nurses are all regulated, and they all each have their own particular statute. But for the purposes of my presentation, I'm just going to highlight a few sections from the Social Workers Act. So while there will be, if you had an opportunity to look at the legislation, some variations in the mandate or functions of each regulatory authority, they're fairly similar. And the main object is to protect the public and to ensure that healthcare professionals who are licensed by that regulator are qualified and competent to provide healthcare services to the people of the province. So if we look at the Social Workers Act, so the object section states that one of the objects, there's many, I just pulled this one out in particular because it highlights the responsibility regarding standards of practice. So one of the objects is to establish and maintain standards of professional conduct, knowledge and skill among its members, and to ensure to the general public the proficiency and competency of the practice of social work in the province and to serve and protect the public interest. Each regulated health profession will have a similar type of provision. And I should say, excuse me, that regulatory authorities are all created as a statutory entity in their individual statutes, and then the legislation dictates what their mandate and responsibilities are. So also under the statute, there is authority to make bylaws. So I pulled out two examples of the bylaw making power in the Social Workers Act. So there's authority to make a code of ethics for social workers and to establish standards of practice. There's also authority to make regulations. There's one example here in terms of continuing competency, continuing education. And regulations generally are developed in consultation with both the regulator and the Minister of Health and Community Services, because the minister has to approve those regulations. And then the duty to report. So not every health profession has a legal or legislated duty to report. And what we're talking about here is the duty to report in the Social Workers Act states that a social worker who has knowledge from direct observation or objective evidence of conduct deserving a sanction of another social worker shall report the known facts to the registrar. So like I said, not every health profession has a legislated duty to report, but I will highlight for you the social workers have that duty, obviously, and so do the registered nurses. I'm not aware that the licensed practical nurses have a similar provision. But having said that, the legislative requirement is the minimum standard. So even though you may not have a legislated duty to report, you may have an ethical one. And Chris will speak to you later about that. So in terms of federal legislation, so I had indicated earlier there's a division of heads of power in terms of laws between the province and the feds, the federal government. So I've talked to you a little bit about some of the examples of provincial legislation, and then there's one example here that you are probably aware of, but is also significant from a practice perspective, is the criminal code. So I've highlighted here assault/battery and medical assistance in dying. So essentially, when we're talking about assault, and I'll explain to you why this is significant in your context, is the code states that an assault is committed where a person, without the consent of another person, applies force intentionally to that other person directly or indirectly. So in the healthcare context, if you treat a person without their consent, it could be an assault under the criminal code, which is why consent and informed consent is so significant. And in battery is a tort similar to negligence, but it's where there is an absence of consent. So we're not talking about was the consent informed? There was no consent. So injecting somebody with a drug without their permission, without their consent, doing surgery. So those are pretty extreme examples, and we don't normally see the tort of battery. The other thing I want to highlight here, and we don't have time to get into it, is just to highlight MAID and the medical assistance in dying. So I'm sure, as you all aware, before amendments were made to the criminal code in 2016, assisting someone to die by suicide or euthanasia was illegal and could be and was seen as murder. So if a healthcare professional helps somebody to die by suicide, they could be charged and convicted under the criminal code and serve and go to jail. So there was a court decision, and the Supreme Court of Canada, which is the highest court in our country, ruled that the provisions in the criminal code violated Section 7 of the Charter of Rights and Freedoms, which is a person's right to life, liberty, and security of the person. So they amended the criminal code to put in exemptions for healthcare professionals to assist someone to die by suicide, so the MAID. So that's all I'm going to say about that, given the time. So in terms of the common law, one example would be is informed consent. So obviously consent is important, and you all know how important it is. There is some legislative guidance on consent in this province. So our Advanced Healthcare Directives Act states that anybody who is 16 and over is presumed to have the capacity to make their own healthcare decisions. The common law is significant because the courts have made many decisions in which they've weighed in on what that means. So in terms of when the age of consent, I'm sure you're all aware of the mature minor concept. So someone who is under the age of 16, who is mature enough to understand the risks and benefits of the treatment that's being offered, may be able to consent to that treatment. The other aspect that the courts have ruled on is what constitutes informed consent. So what information has to be provided to a person in order for them to be able to provide you as a healthcare provider with informed consent. Negligence malpractice, again, this is a legal concept that has been developed by the courts. And what we're talking about here is when healthcare professionals, and obviously negligence can apply to any profession or in many contexts, but for your purpose, it's where there's a duty of care, and the courts have recognized that the relationship between a health professional and a patient, there arises a legal duty of care. Negligence comes into play if there is an allegation that a healthcare professional has not met the reasonable standard of care. And as Michelle indicated in her presentation, so clinical guidelines, standards of practice, those types of things will be important in determining if there is an allegation of negligence, whether the reasonable standard of care has been met. And then obviously there has to be a link between the breach of the standard of care and the injury to the patient. So to conclude, what I'd like for you to take away from my presentation is just to recognize that health professionals do have legal obligations that are set out in statutes and legislation, but also in the common law, which is judge-made law. It can be in criminal, it could be in the federal context, so criminal code, for example, the Food and Drugs, depending on your profession, or maybe things in the Food and Drugs Act, which is a federal statute as well, and then the provincial statutes. All of these are available electronically. You just have to Google them, and you'll end up at the appropriate, either the federal government or provincial government website. And the last thing I want to say is that when you're making your decisions, law and legal obligations is only one aspect. And even though you may not have a legislated duty to do something, you may have an ethical, or it may be a part of your standards of practice. So just to be mindful that the law would be your minimum standard. Thank you.
Thank you so much, Jerry. That was excellent. I'll now call upon Simone to the podium.
Good afternoon, everybody. I'm going to be speaking with relation to the social work perspective this afternoon, but at the end I'm going to give 3 tips, and those 3 tips are really quite applicable to any healthcare professional. Okay, so the Canadian Association of Social Workers Code of Ethics says, a code of ethics cannot guarantee ethical behavior. Ethical behavior comes from a social worker's individual commitment to engage in ethical practice. Both the spirit and the letter of this code will guide social workers as they act in good faith with a genuine desire to make sound judgments. The Code of Ethics requires that members uphold the values and principles outlined in the code. Frederick Reamer, professor of social work and ethics scholar, said, "Over time, the profession has nurtured and refined a set of values that give meaning and purpose to generations of social workers' careers. Values are what we aim for, and values are the lens through which we see the world. Values give us the why we do what we do. The values listed in the CASW Code of Ethics outline our why. And they are respect for the inherent dignity and worth of persons, pursuit of social justice, service to humanity, integrity in professional practice, confidentiality in professional practice, and competence in professional practice." Now, the code doesn't provide us with a set of hard and fast rules for our practice, nor does it tell us exactly how to conduct ourselves in every unique situation we encounter. Sometimes we'll encounter situations where 2 values will be in conflict, and the code doesn't identify which value takes priority. In fact, the Code of Ethics says reasonable differences of opinion exist among social workers with respect to which values and principles should be given priority in a particular situation. While the values listed in the Code of Ethics tell us the why of our practice, the CASW guidelines for ethical practice and the standards of practice for social workers in Newfoundland and Labrador shed some light on the how. The CASW guidelines provide guidance on ethical practice by applying values and principles in the code to common areas of social work practice. And the NLASW standards outline the practice requirements for social workers in Newfoundland and Labrador to ensure safe, ethical, and competent practice. And in 2015, the NLASW created an ethical decision-making model that you can find on the NLASW website, and it takes you through 15 steps when considering an ethical dilemma in practice. So they are, what is the ethical dilemma? Clearly articulate the professional values that are in conflict. What personal values, if any, might be influencing my decision? Is there a conflict between my personal and professional values? What is my immediate reaction or instinct for the best way to address an ethical dilemma? Consult the CASW Code of Ethics and Guidelines for Ethical Practice. Does the code provide direction? Identify the sections from the Code of Ethics and Guidelines for Ethical Practice that are applicable to the dilemma. Consult applicable agency policies and best practice standards. Are there legal considerations? And consult relevant legislation where necessary. What are some of the cultural considerations? Was this issue addressed through informed consent? What are some of the available options or choices for resolving the dilemma? Analyze the risk and benefit of each option. What steps do I need to take to minimize risk and not compromise my ethical responsibilities? Consult with a peer or a supervisor or a manager. Does the context of practice make a difference? Discuss the dilemma with the client where appropriate. Consider the impact on the therapeutic relationship. What other resources might be helpful in my decision making? Document the ethical decision-making process and monitor and evaluate the impact of the decision and modify if necessary. Now, for the purpose of today's event, since it's to explore ethical decision-making and professional judgment in real time, and as we review each of the three scenarios, I'll ask you to keep 3 tips in mind. Tip number 1. Very rarely are we faced with a scenario that requires immediate response. We can all identify with the pressure felt when a client or patient is in distress and desperate for answers. But we can press pause. We can say, this is very important. In fact, it's so important, I need to take some time to consider this, and then I will get back to you. Then we can consult with a supervisor, employer policies, professional resources, or our regulatory bodies. Tip number 2. It's been my professional experience that the potential for ethical conflicts are often due to a mismatch of the public's expectations of our professional roles and boundaries. So to mitigate future conflicts, we should know our own code of ethics, standards of practice, employer policies, and be able to communicate them effectively through the process of ongoing informed consent. Generally speaking, the public doesn't push our boundaries for the sake of boundary pushing. Usually it's done because they simply don't know where the limits lie in respect to matters like confidentiality, privacy, duty to report, dual relationships, and conflict of interest. So, we need to know our limits, we need to be able to communicate our limits, and we need to know how to enforce our limits. And tip number 3, since social work is a values-based profession, and social workers have personal values, culture, and religious beliefs, the code says social workers need to be aware of any conflicts between personal and professional values and deal with them responsibly. Moral distress created by working against one's own strongly held values can lead to career dissatisfaction, which can have grave implications for the social worker or healthcare professionals' mental health and the workplace environment. Moral distress is experienced in all professions. Its antidote involves building a strong team, identifying professional supports within your organization and professional regulatory bodies, self-reflection, self-care, and using your employee assistance program. These strategies can help each of us clear away the moral distress that collects during the lifetime of our careers. So, I look forward to the rich discussion with the panel today.
That's great. Thank you so much, Simone. And now I'll call upon Chris to this podium.
Thanks, Annette. Thanks for coming, everyone. Welcome. So I'm Chris Capozzi. I'm one of the ethicists affiliated with the Faculty of Medicine, and I'm also involved with ethics consultation and ethics committees with Eastern Health and the Provincial Health Ethics Network of Newfoundland and Labrador, which I'll mention in a bit in more detail. So what I'm going to do is just sort of try to contribute to this discussion just by giving you 3 sources of ethical insight that can be brought to bear on clinical situations where you might have concerns about ethics. And I'm going to look at them, I guess, from the perspective of someone like me who deals with ethics issues all the time. And maybe that will give you some resources for thinking through ethical issues in your own practice. So the first source of ethical insight that I'd like to mention has been mentioned already. I'd like to elaborate a little bit on it. So codes of ethics are important. This is your first source of ethical insight when dealing with a particularly difficult ethical issue in practice. You're professionals, you should know these codes already to some degree. These are useful documents because they provide us with 2 different types of things. So they provide guidance as professionals. The 2 types of things the 2 types of information that they provide are, on the one hand, you'll always find statements of values in codes of ethics. So sort of overarching values that are meant to guide your practice. You can take these values, sort of general principles, and in looking at them, think through, well, how would I apply these particular values to a specific situation that I'm confronted with? And you'll see that particularly this type of instruction or source of insight in social work code of ethics. Another thing that you often find in codes of ethics are really concrete forms of direction about how to deal with specific types of conflicts or duties. And if you look at for instance, the nursing code of ethics, there's a lot of material in there that's pretty concrete and actually very helpful for specific situations. So one issue that I am familiar with, I once consulted the nursing code of ethics for, was the issue of conscientious objection in nursing. So for instance, if you're in the moment and you're in clinical care and a patient is requesting a particular form of care to which you have some form of objection, religious objection, ideological objection, just some sort of moral objection to providing that form of care, what is your obligation? What duties do you have to fulfill that request? And it might differ depending on what's being requested. And for help in dealing with a situation like that, you can refer to the nursing code of ethics, particularly if you're in an area where certain types of issues come up frequently. You can sort of familiarize yourself with what the code of ethics says about how to deal with situations like that, and that is a source of insight. So values and also pretty specific instruction. Just to one degree or another, you'll find concrete direction in some codes of ethics, but not others. But as Simone mentioned, there's for the social work code of ethics, there's also practice guidelines on how to apply values-based reasoning in particular types of scenarios. So those codes of ethics are supplemented by other further kind of statements provided by regulatory bodies. The second overall source of insight that I'd like to point out are ethical principles. Now these are unwritten largely, but very important. They're often implicit in our practices. They're part of sort of expectations that are built in to what it means to be professionals. Here I've outlined 4 different ethical principles that you often find in ethical reasoning. If you look at texts in bioethics, these are really kind of prominent ethical principles. So there's respect for autonomy, non-maleficence, in other words, do no harm, beneficence, which is the obligation to do good, and the principle of justice. Now, these 4 principles are kind of general rules of thumb, things you should be thinking about when you're confronted with an ethical dilemma in practice. By stating them as principles, I'm not ordering them in terms of priority or anything like that. They're all very important, and depending on the situation in which you're trying to think through the ethical issues, one principle might have priority over another. And that's for you as a professional, as a moral agent, to figure out. And that's what's tricky about ethics. Trying to figure out which principles, which duties, which obligations have priority in a specific situation. So respect for autonomy is all about, for instance, providing getting informed consent for procedures, interventions that you're providing from patients. Respecting confidentiality is another aspect of respecting autonomy. It's all about treating the patient with respect, and protecting their information, their privacy is part of that. Non-maleficence, do no harm. It seems pretty standard, pretty obvious. You want to avoid doing harm to patients. But this principle often runs in tension with respecting autonomy. Respecting autonomy means that you often defer to patients about what they consider to be harmful or beneficial. So by having a principle that's asking you to do no harm, what that means oftentimes is that you're going to have to defer to what the patient considers to be harmful. But not always. That's the thing. It can be a principle, an obligation to do no harm in situations where patients are requesting something that you consider to be harmful. And in those situations, it's often the case that your obligation to avoid doing harm can overrule the request, can overrule an autonomous request. So oftentimes, non-maleficence can be more important than respecting autonomy, and that's the tricky part about trying to balance these 2 principles. Beneficence comes into play in situations where, again, you might not necessarily be deferring to a patient's own definition of what's good. You're bringing your own sense of what's good to the situation, a professionally informed sense, an evidence-based informed sense of what's good to a situation. And that obligation can again have priority even over situations where someone is making a request for something else. Maybe it's a substitute decision maker deciding on behalf of someone, and you think it's important to go in another direction to provide a different type of intervention. I should highlight that beneficence, often when we're talking about prevention, beneficence comes into play. And justice is a principle that comes into play when you have multiple people competing for scarce resources, limited resources. How do you fairly allocate resources when you can't satisfy all demands? That's one aspect of justice. Another aspect of justice is social justice, fairness, reducing oppression, and things like that, ending stigma. These are all important ethical principles that come into play in clinical decision making. A third source of ethical insight is even more kind of amorphous and unwritten than the 4 principles. It's your own ability to reason ethically. And this comes through a lot of practice, through mentoring, through education like this. It's really important to sort out when you're confronted with an ethics scenario, what's the issue? What kind of case are we talking about here? Oftentimes, identifying the type of case that it is done through previous experience. This is a case sort of like one that I experienced in the past, and this is what we did then. If you can put your finger on what the case is about and sort of zero in on, in an analytical way, what the issue is, this is very helpful. So is it a case about decision-making authority? Who gets to say whether or not this intervention should go forward? Is it the person with capacity? Is it a substitute decision maker? Does the healthcare worker have some sort of veto over this decision? What interests are in play? How do we balance those interests? Is it an issue of standard of care? Am I worried about a reduction in standard of care if I go forward with this plan of action? That's troubling. Is it about organizational obligations? Is it larger than you? Are there sort of cross-cutting interests that go beyond what you're doing in your own clinical environment? Often we'll get ethics consultations where acute care has to be talking to mental health and addictions and trying to figure out ways that those different sets of values and priorities can be balanced. Is it all about communication? Is this conflict due to a breakdown in communication, and how can you facilitate better communication? Another thing you have to think about is what is possible. Are there limited options here? Is there only one option? And one further concept that I don't have listed here that others have mentioned, I think Simone mentioned, is moral distress. So is this an ethical issue for me because it's distressing, I'm being called to do something that actually conflicts with what I think is right? So being able to put your finger on what is that issue, analyze it, cut through all the details that aren't totally relevant is very important in solving the issue from an ethics lens. So those are the three sources of moral insight, ethical insight. I'd just like to end off with putting in a plug for the ethics service that's available to all of you in Eastern Health and all the other regional health authorities across the province through the Provincial Health Ethics Network of Newfoundland and Labrador. If you're troubled by a particularly complicated ethical situation and it requires some further discussion, you can ask for an ethics consultation. The model that we use here is that the people who are involved in the case, the mix of people who are stakeholders, get together with resource people, including an ethics facilitator and an ethicist like me, and you confer about the case and you come to a consensus about how to proceed, and you formulate a few recommendations about how to proceed in the case. As professionals, one really valuable thing that I see nurses and social workers doing is calling ethics consultations on behalf of clients or patients or residents. These are people, they're entitled to ethics consultations as well, to asking for them, but they're not often aware of this as a resource. But the professionals who are acting as advocates for them are aware. So if you can advance that as an option on their behalf, then that's very valuable. And just up here I have the phone number for the ethics service and email address for making a request for an ethics consultation. So that's it. Thank you.
That's great, Chris. Thank you so much. And now I'll invite Molly to the podium.
Oh, I'm sorry to see the young nursing students go, because you're the future. Thank you for coming. It's a real pleasure to be here and to talk about these kind of issues. I want to bring it into for my part, I want to bring it into practice a bit more. And I'm going to start off with, I want to spend a little bit of time talking about definitions. And in particular, I want to talk about clinical decision making. And I'm going to talk a little bit about accountability in clinical practice. Michelle set the scene talking about it from a regulatory perspective, but I'm just going to remind us how important it is in clinical practice as well. The other part is we're here because of patient-centered care. and I want to focus a little bit on patient-centered care and bring into our discussion the cultural safety and humility aspects of our practice. And last but not least, just spend a little bit of time talking about the importance of documentation and the importance of listening in our practice. When you look at the definition of clinical practice, there's a lot of different words that are used to mean the same thing. You can hear it being called clinical judgment or problem solving or making and taking decisions or critical thinking. And often these words are used very interchangeably. The interpretation or conclusion, though, of a health professionals about a patient's needs or concerns or health problems is also very important, because that adds to the decision-making process, whether you take action or not. And lastly, of course, whether you're acting or not, your decision is based on your standard approach, or you may improvise depending on the situation as well, to the patient's needs. This is the diagram I became familiar with when I was doing my own PhD work. And it comes out of South Africa, but it's the base of accountability. And at the very base of it is our ability to do something. And then, of course, you have to have the knowledge and skills, and your values and attitudes makes a huge difference, as we already heard. Now, your knowledge and skills obviously comes from your professional practice, your professional learning and education. And for myself, because I'm a nurse, that's where my base came from. But I went on and studied other areas as well, including constitutional law and accounting and other things. So my base expanded quite a bit away from clinical to more administration. But we start off in our basic education, and then we go on into areas of specialty. You also have a responsibility for your practice, and that responsibility is led through your code of ethics and through your standards of practice and other documents that are put out by your regulatory boards. And of course, in order to work as a professional in a health organization, you have to be given the authority to work. And you may have a fairly big scope of practice, but you'll find that your job description is not necessary as full a scope of practice as would be the case from a regulatory perspective. So your job description gives you the direction for what you're allowed to do in your practice, along with your legislation and your regulation. And then, of course, last but not least, accountability. And accountability is really important because we're accountable to the public and to our regulatory bodies and government, but we're also accountable to ourselves, individually as practitioners, and to other health professionals too, especially when you're working in teams to bring the best part of you to work every day. I want to talk also about patient-centered care. Now, patient-centered care can mean different things to different people. If I'm a patient coming into hospital, I have some preferences and values that I bring with me, and I want to be treated as a whole person. I don't want just to have something done to me. I want people to understand my needs as a person. From a clinician, though, you may be focusing on patient-centered care around advocating on behalf of the patient. And organizations often tend to look at person or patient-centered care by putting people on committees, patients on committees, or using satisfaction surveys to find out opinions and to help them to form decisions. Policymakers, on the other hand, could be looking at the performance of an individual organization and the health system at large. And of course, there's a lot of attention today on public spending because we tend to spend a lot of money on our healthcare system, and the question is always asked, are we spending it the right way? And last but not least, the public health sector may be looking at determinants of health, social determinants of health, and trying to prevent citizens from having to become patients. So it's really dependent on your perspective. British Columbia, the Ministry of Health in British Columbia, have set out a framework for patient-centered care. And as you can see from this framework, it's pretty complex what we mean by patient-centered care. We don't have time to get into it, but I just wanted to present this to you to recognize that when we talk about these kind of concepts, they're not easy necessarily to grasp. But there's a lot of attention to patient-centered care now because our system tends to be focused a lot on providers, the needs of providers, and of course we need to really keep our eye on what patients need. And we need to, as has been said by my colleagues, there is an importance of prioritizing in some cases. And making sure that what is done with quality. Having a vision where we want to take our the system and basing it on principles. And of course, principles are nothing unless they're put into practice. The other piece that I think is really important to bear in mind as we're thinking about our clinical practice is that when we go to practice, we have to be thinking about the culture of the person that we're working with. And if we look at a westernized model of care, we'll probably, which most of our system is built around, it's very individualistic. But if we look at a culture that's more collective, like indigenous culture, it's not so individualistic. It's more centered around the family and around different community aspects and stuff. So I just wanted us to be mindful of patient culture, safety, and humility as we talk through, in particular, our dilemmas in our care. Further, I wanted to mention clinical judgment. When we talk, I mentioned already clinical judgment, what it means, and decision-making. But Tanner did some work in 2005 where she really looked at nursing practice and came up with a model around how nurses, and I do believe it's not just nurses, I believe it's other health professionals as well, make their decisions. And often in nursing you hear about the nursing process, but she said we don't really use the nursing process. What we do is we have a base for our practice, which is our knowledge, and we have a lot of experience. When you're new in practice, you don't have the experience, so you tend to use your knowledge a bit more. You have your ethical perspectives that you learn as well, and then you get to know your patient. And there's a certain expectation that when you go into practice, you look to see what's going on, of course, so you're noticing things. You're recognizing patterns, you're trying to identify the problems. Then, of course, you have to interpret them. And interpreting is where you begin your true decision-making and your prioritizing. Then, of course, once you've gone through that, you have to respond, and so you make a clinical implementation of something that you think will solve the problem. And as has been mentioned several times already, you spend some time in reflecting and thinking about what you've got from the situation, whether it worked and whatnot. And all of this is set within a context, of course. So it's not a simple, clinical decision-making is not all that simple, and it's really based on a lot of the things you've already said. I want to also mention how important it is, and Michelle has already talked to this somewhat, to document. You know, documentation, no, it's not always the easiest thing to do. It's really the evidence that you provided safe and competent care, and you did it in a timely manner. And of course, the evidence that you followed your standards and your procedures, and you met them. And it's evidence that action was taken in a reasonable and prudent way. And it must be consistent, of course, with the policies of the organization. Documentation is not separate from care, and it's not optional. We have to do it. And you have a legal and professional accountability, as Michelle has mentioned, to document according to your standards and to your policies in your organization. And of course, as we all know, poor documentation can lead to quality, can have a really significant impact on quality patient care. And it also, if you are found negligent or you have to go to the court system and defend your actions, it can be often against you. On the other hand, if you have good documentation and you're able to show what you did and how you did it and back it up, then you have a better chance of being able to defend yourself. Last but not least, I want to talk just a few minutes about listening. We mentioned already how important communication is. And I think a lot of times we talk about communication, but we often overlook listening. And listening, as this diagram shows, has different levels. A lot of us listen through habits. and we already have our mind set up and we listen at that level. But if we're really listening and focusing on what's going on, we have more of an open mind. And then if we're really empathetic listening, we would connect differently with people and see them through their own eyes. And so you have more of an open heart to your listening. And last but not least, the level of being open and open will. So connecting to the highest future possibility that seems to emerge. And the reason I say these is because listening, when we're going to talk about the case studies in particular and some of the ethical dilemmas that we face in our practice or overlook in our practice, really comes back to whether or not we listened and what level we listened. So that's the sort of setting the stage from my side of the gurney, as they say, and I'll turn it back to Annette.
Wonderful. Thank you so much, Molly. And a huge thank you to all of our panelists for presenting here this afternoon. Certainly, accountability in practice means being committed to enhancing one's competency, adhering to our professional ethics and standards, and maintaining the best interests of clients. So I want to thank the panelists for highlighting the areas that do need to be considered when making practice decisions. That includes our ethics and standards, organizational policies, and our legal and legislative responsibilities. You've each provided tremendous insight into the topic in a very short time frame, given us a lot to reflect on, and particularly as it relates to our own practice, and certainly challenged our thinking. I really like that we focused on decision making for this event today, and now look forward to the case discussion. So I'll invite my colleague Peggy to present the case scenarios.
Hello, everyone. So I just want to thank Annette for introducing the event and thank the panelists for their overview of their specific roles and their presentation. So the next thing we're going to do is we're going to go through some case scenarios, because as healthcare professionals, we're often have to make decisions in this specific moment in time. So all these things happen in this one specific moment in time, and then you have to run through the regulatory responsibilities, your legal responsibilities, your employer accountabilities, as well as your moral and ethical accountabilities. So when we go through the cases now, think about your own practice in your practice settings. Think about what each of the panelists have said. Reflect on what you would do in the situation, like when we go through it, and then see if it's different from what each of the panelists would say. So our first case, and I'm going to read it from here because I can't see. So they're very special cases, difficult. You are a healthcare professional who is working in the area of mental health and addictions. A neighbor asks you advice on dealing with her rebellious teenager who is using drugs. The youth is on a wait list for services, and the neighbor asks you, given your expertise in the area, could you help her daughter while they wait? As a prestigious member of the community, the neighbor feels that the privacy and confidentiality of her daughter would be better protected if she remained outside of addiction services and that there was no documentation regarding her addiction. So she wants you to help on the side. The neighbor also disclosed that she feels an extreme amount of stress because her daughter has illegal drugs in the house, and it was cocaine and fentanyl, and that she is at the end of her rope. So very complex case. We're going to have each of the panelists provide their perspective, and it's going to come in order. So Chris is going to speak first, then it's going to be Simone, then Molly, and then Michelle, and then Jerry. So you guys can just speak your speak and then go on to the next one.
Okay. Is there a way of turning it on? It's on? Okay. Okay, great. Thanks. So I should preface this by saying that we, fortunately, were provided the cases with beforehand. I say fortunately because it'd be difficult to sort of figure things out on the fly. And if you think that there's any really great ideas that come out of our analysis, it's because we've had a chance to reflect on them and actually discuss them amongst ourselves. And that sort of is evidence, I think, of the need for reflection in dealing with complex cases, even though as the case as it's posed doesn't really provide for a lot of opportunity for reflection, which is also interesting. So I have a few things to say about this case. I think, what is it about? There's a couple of things that it's about. One of them is this suggestion about midway through where the question that, given your expertise in the area, could you help her daughter while they wait? And I kind of wonder what's the ask here? What's being proposed? Is this sort of a prelude to asking whether you can help her daughter skip the wait list or jump the queue in some way, which would obviously be very problematic as a way of allocating this scarce resource of addictions care. So we don't usually allocate time in this form of care on the basis of who people know. There are other more just ways of allocating that form of care. I also wonder, so the mother is very worried about there being some kind of documentation that her daughter is under addictions care. I wonder what her worry is based on, and that's sort of if I was in this situation, something that I'd ask about. I do know that it's actually true. I mean, people with addictions do face a lot of stigma in accessing health care, and the people who hold the negative beliefs that stigmatize people with addictions are professionals. And so there's some legitimacy to that concern. I'd like to think and hope that it doesn't happen so much around here, but you never know. I mean, I've seen evidence of it documented other places in Canada. That said, what she's requesting is care provided outside of a sort of normal healthcare environment. And it doesn't really seem that there's any way, if you're a professional, that you could actually provide a standard of care for addictions care outside of that environment. So there needs to be a balance here between providing the standard of care and this supposed protection that she's going to have by not having documentation about her addiction. And I think if she's hoping that the care that she's going to receive for her addictions is actually going to be worthwhile and effective, then you really need to fulfill the standard of care. So the request is kind of, even though there might be some basis for it in her worries, the request seems kind of off base if she really wants to help her daughter. Yeah, so that's all I have to say. I'll let others pick up the discussion here.
Okay. Well, I think I'll be a little bit of a public service announcement for the NLASW, for the social workers, because I have a number of resources that we could definitely draw on in this situation. And so I just wanted to point out that I'll be talking from the code and some of the values that we can highlight in this, as well the standards of practice and some of the resources that are found on the NLASW website, like the Ethical Compass and Practice Matters. We actually just had completed, as the Ethics Committee, an Ethical Compass in November. Can you help me? The ethics of giving professional advice to a friend, neighbor, or colleague. So the first thing that does come to mind immediately is the potential for a dual relationship. I guess if we were to go back to the decision-making model that I had talked about at the beginning, one of the items on it is context of practice. So my context of practice is a little different than most everybody here, because I don't actually work for a healthcare authority. I do work in private practice. And so that does make a difference, because if a neighbor were to approach me, that is actually a service request. And
And so immediately I would have to put my professional hat on in order to identify the issues around there being a dual relationship and the ethical reality of that, and kind of weighing out the costs and benefits and of whether to proceed or how to proceed. The other thing, if I were to go back to the code, I think of value 4 in the Code of Ethics, which is integrity and professional practice. So social workers maintain a high level of professional conduct by acting honestly and responsible and promoting the values of the profession. And that makes me think to some of the fears that this mom has about the implications, as Chris mentioned, for getting service in the healthcare authority, and give an opportunity to educate her on privacy and confidentiality and how healthcare will be delivered. Social workers, under one of the principles of Value 4, social workers demonstrate the adherence to the values and ethical principles of the profession and promote respect for the profession's values and principles where they work or with which they have a professional affiliation. So I would come at that to educate her a little bit on how that works, where she's accessing care. The other thing that I might consider too is, well, the who's asking for help, because I see that there's 2 people here that need help. There's a mom who's at the end of her rope really struggling with taking care of her young person, and there's also the young person. And I don't know if the young person wants to participate in care or if this is maybe something that mom might really want. So as a neighbor, I am a social worker, I can't take that hat off, but as a neighbor, I would encourage her as well to seek out support, either through EAP or through community services as well, because of course loved ones of individuals with substance use and abuse issues also need support. I point to the NLSW standards where it talks about where a dual or multiple relationship exists, social workers are responsible for ensuring that appropriate boundaries are established and maintained. We're neighbors, and even if this woman and her child accesses services through the healthcare authority, we're going to continue to meet, right? Maybe out in the yard, out gardening or shoveling snow. And there may be times where, again, I might have to kind of reiterate kind of where the boundary lies between us being neighbors and me being a professional, and always encouraging her about asking, redirecting her to the professional services. Now, another thing to continue is we operate on the assumption we're in the city. In much smaller communities, there's less availability of services. So the location and availability of services also may be something that might need to be considered when somebody is seeking assistance. But those are just a few of the things that came to mind at first, and we'll probably have a discussion after, so I'll leave it at that for now.
I think most of the things Simone has really picked up on. And thing I would emphasize too, what is the state of the mother's health? And she's very anxious, and she's very overwrought with what's happening to her daughter. And, does she really understand what's available to her in her community? And there's a lot of different mental health services that are available now in relation to addiction problems. And does the mother really understand the significance of getting her daughter's help as soon as possible? Because cocaine and fentanyl are not drugs that should be played around with. They do damage the brain and other parts of the body. So I think having some conversation, frank conversation, and being realistic too, that you are a health professional and you're bound by your standards and you can't just let it go. The other thing that comes to mind that hasn't been mentioned, how old is the daughter? Is the daughter a mature minor? Is the daughter a young, who is this daughter? And what does the neighbor, me as the neighbor, what do I know about the daughter too? So there may be other things that you need to consider.
From Molly's comments, and just to say, as the professional is considering whether or not the ask to intervene and actually provide some service to the teenage daughter, they would have to consider in this situation that should they decide that they are going to provide service, that they're going to be held accountable to the standards of practice and the code of ethics. So it's an all-in sort of situation. It's not lessened in any degree the requirements to adhere to the standards in the code because this person is your neighbor, or the teenage daughter is, your neighbor as well. So they have to consider that. And when I think about that, let's just say the person did decide that, yeah, I'm going to intervene and provide some service. They have to think about, in nursing, we would say the nursing process. So, you're going to do the assessment, you're going to do a plan, you're going to put your plan in place, you're going to evaluate it. But part of that, as Molly mentioned, is documentation. It's a must-do, it's a requirement. So I would consider it, if they did take this on, it's almost like a self-employed or a private practice situation like Simone has mentioned. So where is the documentation going to take place? Where is the documentation going to be stored? That person would have to look to the Personal Health Information Act, the requirements under the Act, because taking on providing service in that situation makes them a custodian. Jerry will probably have some comments on that. So where exactly are they going to store this documentation? The other thing with respect to the mom is the professional is going to have to say to the mom, I cannot not document. That's a requirement, that's a standard, so I can't say to you that I won't document. And the panel has already discussed exploring some of the reasons why the mom feels that way. Some other things that I would think that they would have to reflect on is, again, the mother is looking for, confidentiality, full confidentiality, but as a professional, situations arise, there makes things come up in practice, and managing that, I may need to consult with others. So again, you would have to be clear with the mother in saying that, in providing a service, I may need to access others. Another thought, and I think it's come from some of the panel, I think Chris has mentioned about the wait list. I don't know what the person's day job, if you will, the employer requirements. If you're going to work outside your employment setting, having some discussion with them, particularly where you pick up, in this case, the wait list. Not that I'm saying that they have to tell the employer the name of the person or anything like that, but to discuss if you're going to be working off hours and providing the same service that you provide during the day. As Chris mentioned, some concern about like jumping the list. It may be perceived in that way. And the final comment I would just make is, if the person were to undertake this service, maybe they would need to have a discussion with their liability provider just to see if their liability extends to this type of a practice.
Just picking up on what Michelle said there in relation to being mindful that if you're working in an organization and you're doing private practice on the side, we have clear policies about that, and you should really look into that before you go taking on something like this.
I guess from my perspective, from the legal perspective, there's a couple of things that I thought of when I first looked at this scenario. And obviously, FHIA, or Personal Health Information Act, as Michelle indicated, health professionals, by virtue of being a regulated health professional, are custodians under FHIA. So you would have certain obligations that excuse me, you may not have if you're working normally with a regional health authority, where the regional health authority is a custodian and you're an employee of a custodian. So the relationship and your legal obligations could be different. The other thing that I thought about is in terms of I think Molly had mentioned the health of the mother. And I mean, we don't have obviously a lot of information, but in terms of stress at the end of her rope, what came to my mind is the duty to report under child protection legislation, and whether or not that duty, based on the information you gained during that relationship or that conversation with the mom, if your duty to report is triggered. And obviously, I mentioned it briefly in my remarks, but there are specific sections in the Children, Youth, and Families Act which sets out when you have an obligation to report, and that duty to report overrides any obligation of confidentiality you would otherwise have towards a person. So those were two things. The other thing, in terms of the documentation, all I want to say is really that is a record of the service or the advice that you provide to a patient or a client. And it's important because memories may fail over time, and that documentation is evidence of what you said, what services you provided, and it can be used as evidence in the event something goes wrong in the relationship. And there's a breakdown, and then, for example, there's a court action started, that the court, depending on the existence of the documentation, when it was created, if it was contemporaneous with the service, will give a lot of weight to that record, and it will be reliable in terms of, I guess, evidence of what service you provided. Molly touched on this. When I first looked at this scenario, I wondered, what if the scenario was kind of turned around? So the daughter approached you and said, I have this issue, but I don't want my mother to know. So then we get into the issues of consent, the age of the daughter, and whether or not she has the capacity to consent and make decisions with respect to her own health care. And that just touches on what I had mentioned earlier around the Advanced Healthcare Directives Act provides some guidance, but also the common law and the concept of mature minor may also provide some guidance. And then who do you owe the duty to obviously to the patient, which would be the young person, and what you can and can't say then to the mother. So those were the types of things that I thought about in that scenario.
I just had one other thing that occurred to me there as we were talking, and I had written down earlier about when we set limits as well as a form of self-care for ourselves, in that all of us being helping professionals at some point or another are probably approached by someone who knows us and what we do and may ask our professional advice. And depending on how stressed the person is or what kind of crisis it is, it could be a recurring event. So as a function of self-care, it's also very important for us to clearly outline what our professional limits are and to maintain those boundaries.
So that was a really complex case, and I hope that the panelists gave you some things to consider that you probably wouldn't have considered in that moment of time. We're going to go on to case number 2. And case number 2. So a patient is admitted to a medicine unit for end-stage COPD. The patient was accompanied by wife and son and was assessed for swallowing, and it was determined that he was a choking risk, and he was ordered a puree diet. The Thanksgiving holiday was approaching, and the patient requested that a jig's dinner with all the trimmings, salt meat and everything, that's what he wanted for his Thanksgiving dinner. So the wife went to the healthcare professional and demanded that the husband is not to eat jig's dinner, and that the conversation that she had with the healthcare professional was not to be disclosed to her husband. So for case number 2, we are going to begin with comments from Molly, followed by Simone, Michelle, Jerry, and Chris is going to close.
The first thing when I thought of, when I read this case study, I thought about the stress that the wife must be under, and I wondered if the choking was not a new situation, and if he had choked at home, and maybe that was the cause of her bringing him into hospital. So there may be stress. She may be under a lot of stress as well. So one of the things as a health professional I would do is take her into a quiet area and just talk to her a little bit more about her experience of her husband's health and the choking episode. Then I would need to help her understand that, if the patient or individual wanted to eat and wanted to take the risk of eating, we are there to help him with that risk. There may be things that we can do. We do have a policy that helps to direct us in relation to these kind of more complex situations. So I would encourage everybody who, if you're ever faced with this, to read up on that policy. And but one of the things we could be offering is to have a pureed jigs dinner, and it is possible. And to have maybe when we eat food, of course, it's the smell and the texture and things, and maybe even to help to start with a pureed of peas pudding or whatever. So see if the person could swallow without choking, and put some safety tips around him while at the same time respecting him and his ability and his willingness to take a bit of a risk. But I think that at the end of the day, you'd have to tell the wife that you just can't go off and stop the patient from not having dinner. It's something that you have to work through. It's not as simple as just her not wanting to have it happen.
So a number of things to consider. As already mentioned, of course, the facilities policy regarding the matter. Also around kind of who is the client, who is the patient, it's evident that this gentleman is the patient and that the care team is involved, and kind of the boundaries and limits about how services are delivered, and what is to be shared through informed consent from the patient and the wife. Also, the issue of self-determination. Value 1 in the CASW Code of Ethics, respect for the inherent dignity and worth of persons. Social workers hold up each person's right to self-determination, consistent with the person's capacity and the rights of others, and they respect the client's rights to make choices based on voluntary and informed consent. Now, mind you, as Chris had mentioned in his first presentation today, we have to balance out self-determination with the safety policy and the procedures that are in place by the service provider, and how the meals are provided. And that's not something that I could speak to, but there has to be balance between the risk that the center is going to enter into, balanced with self-determination of the client. And then, of course, it makes me think of confidentiality in professional practice, right? Kind of really clearly outlining between the couple who is the client, the patient, and these discussions need to be had with the patient, but also recognizing, as Molly had said, that this woman is distressed. Clearly, her husband is being treated for end-stage COPD, and she may also require support for herself.
I'll take it up from here. I don't have a lot of different to add because I certainly agree with what the other panelists have said, and certainly you would see in the Code of Ethics for registered nurses, it's a value there that nurses uphold clients' right to self-determination, even when the choices is something that would put the person at actual or potential risk. So it's a situation where the nurse or the practitioner as well would have to reflect on their own feelings about the circumstance. They may not agree with the client taking risk, eating the jigs dinner, full-on jigs dinner. They may feel that, yes, they're actually at risk, and identifying that I don't agree with it, but when they're providing the care, of course, they have to do so that they're not putting any judgment on the situation for the client. With respect to the wife, again, upholding and advocating for who is the client here, but also helping in the situation with the wife to help her understand the perspective of of her spouse, and working with that, as Molly has mentioned. And the last thing I would just mention, in this circumstance, Molly mentioned there is a policy with Eastern Health, and it's come through the presentation, is remember, excuse me, the importance of documentation in regards to this situation.
Yeah, so I guess just to reiterate, I'm not going to get into it, but obviously capacity and informed consent would be legal consideration as well as the obligations under FIA, our Personal Health Information Act, and the duty of confidentiality and privacy. When I looked at this scenario, I thought about, well, we're assuming that the husband has capacity to consent, but what if he doesn't? So then what we would do, obviously, our healthcare professionals, you would look at whether or not he has an advanced healthcare directive, and if he has named a substitute decision maker. In that particular legislation, we define healthcare decision very broadly. So it may be that because of the risk associated with him and the choking risk, that may be considered a healthcare decision, and the Advanced Healthcare Directives Act would apply. And as you know, in the absence of a directive, then the legislation does provide guidance as to who can then act as a substitute decision maker, and it goes down in, I guess, descending order. So you start with number one, which is spouse, then you go to children. So then I thought, well, what if we had a scenario where the woman who is presenting with the man is a common law spouse, or what we would refer to colloquially as a common law spouse, but that the man had been married, was separated, and not divorced. So he has a common law spouse and a married spouse. So who, and maybe they're both on the scene. So who would you then, who then would act as the substitute decision maker? And it's complicated because the legislation doesn't define spouse. So it can be difficult depending on the situation as to determine who can consent then on behalf of that person. So then I thought, well, what if he's not married? What if he's doesn't have the legal capacity to make his own decision? He doesn't have a spouse, and you have children, and you have multiple children, and they don't agree. What happens then? And so obviously the Advanced Healthcare Directives Act would provide some guidance in terms of, well, if you have children, you have to have a majority decision. And so there, depending on the factual or the facts as they present to you, the legislation would provide some guidance, but there can be gaps. And for example, in the scenario where I talked about maybe there's two spouses, then the law is not going to help you. So then you need to look at what other tools are available in terms of helping you determine how to handle that particular situation.
So about 8 to 10 years ago, we had a series of ethics consultations about this type of issue, so feeding issues in long-term care, where swallowing was an issue, and there was requests for solid food, and it was very troubling. Different ethicists had different opinions. There's a lack of clarity about how to deal with situations like this. So we embarked on a series of consultations with stakeholders involved in cases like this, so people on the ground, people in long-term care, speech pathologists, physicians involved. We got a legal opinion. We did a sort of an environmental scan to see what other policies exist across Canada, and eventually formulated a set of guidelines that really favor the informed consent and autonomous wishes of patients or substitute decision makers who are making requests like this for solid food, even when they have swallowing issues. So eventually those guidelines were put into a policy, Eastern Health policy, called Food-Related Risks Guidance when Caring for Patients, Residents, and Clients. The policy does state, yes, that there's, in this sort of scenario, assuming that the patient is the one making the decisions, he has capacity with that assumption that if his consent or his request is informed to have Jig's dinner, then he should be provided with that. But that's not really the only thing that the policy states. I mean, the policy, informed consent itself is really an important concept here because it's really important for the patient to know what the possible consequences are of him being provided with this meal that he's requesting. Does he truly know that there's a risk of choking? He probably does, but it's something that you would want to sort of unpack before actually going forward with this request. And also the policy recommends pretty extensive consultation with the healthcare providers involved in his care, so that they're prepared for what's going to happen and make it as safe as possible, even though there is an element of risk there. So there's some guidance provided by that policy. And as far as the wife's request, you want her involved in this situation, even though she's sort of taking over the authority or trying to take over the authority to make this decision. Even though she might not have that authority, you really want to have her involved in the decision making here.
I think another piece that's really important, say that the person did decide to eat the food and say he choked and died, or even if he didn't, or he went through a bit of a choking situation, that debriefing and sort of coming to terms with what happened would be really important for the practitioners in particular and the family in general. So it's not just when it's over, it's over. It's also a continuation because it can lead to a lot of moral distress and afterwards too.
So that was case number 2. I keep going back to what the panelists introduced initially, how each of these roles overlap and how there's consistency between what law is and what the regulatory body says and what the employer says and the ethical considerations, and how as healthcare professionals we really have to self-reflect when we come up with these complex situations. And for me, when I read it, I was, you want to do what is best for the client at that moment in time, especially considering they're in stage COPD. But at the same time, you don't want to cause any harm. And I'm reflecting now on how what everybody said has been coming together. So before we start the last case, okay, so it is a long-term client, has been diagnosed with a terminal illness and has been given 1 year to live. The family has strong religious views, and the client has noted that the family is against the concept of medical assistance in dying. The physician initiated a conversation with the client about MAID, and the client has requested from you that the process be started, but that the family members not be told. The client also disclosed that before she dies, that she needed to confess that her firstborn son was not her husband's child, and that she does not want that documented. So for this, we are going to start with Jerry, and then it's Michelle, Chris, Molly, and Simone. You're going to close.
So I guess with this particular scenario, I would have all kinds of questions around medical assistance in dying and whether the criteria for eligibility have been met. So I won't get into that. I guess just to highlight that, as I indicated in my earlier remarks, that there is protection in the criminal code for those who assist a medical practitioner or nurse practitioner in terms of the administration of MAID. So important to keep that in mind. Also, in terms of FIA and what our privacy legislation tells us about the disclosure of personal health information and the relationship, I guess, in terms of the confidentiality between a patient and a healthcare professional. In terms of the declaration or confession or whatever, I mean, that is not, while it is private and personal information, it's not personal health information. Sophia is not going to help you determine how you address that. But I expect that there would be guidance in the professional standards or ethical guidelines, which may assist you. But again, the law in terms of privacy is not going to help you figure out how to address that particular declaration.
For this case, a couple of things that come to mind when I reviewed it. Of course, again, this client, you would be upholding and supporting their rights to self-determination, to make a decision. They've made the decision that they want made. They've mentioned about their family having religious beliefs that they would not be in agreement with MAID. And I think for professionals who are practicing areas where MAID may be provided, that you would be examining your own beliefs about it, because the legislation has provisions that it doesn't require or compel a registered nurse, licensed practical nurse, or other health professional to participate or aid in MAID. But if I identify that as a registered nurse, for example, I need to bring that forward in my employment setting so an alternate care provider can be provided. And in the period of time that that's being put together, I'm still obligated to provide care to my client and certainly in a way that the client doesn't know that I have beliefs that differ from theirs. With regards to the privacy and confidentiality, I would just, echo what Jerry has said. And I guess, the discussion within the team, make sure the team is aware that, this is the client's wish that it not be discussed with the family, so that there's not, an inadvertent discussion that would happen and that information would come out. The last piece of information, as Jerry said, the disclosure about the child. If the practitioner was unsure how to deal with that, then I think it came out in Simone's about taking a pause. And you can meet your standards by seeking consultation, seeking other additional information and resources if you're not sure how to deal with that piece of information. Thank you.
So the information here is a little bit sparse, but I certainly would like to know more, if I was in this situation, about the family dynamics. How close is she to her family? Is she estranged? Are they relatively close, but she just doesn't share the same religious views? What's going on there? I kind of wonder, because in a way, I mean, it's totally justified for her to withhold this information from her family, and you have no obligation to share it with her family. But when you think about the process of MAID, it's not usually what happens. Usually people have their families with them when they die. And in a way, it's kind of impossible to keep that information from them, from the family members, if she's relatively close to them and if she wants them to be involved in the MAID process towards the end. So there's a little bit that's missing here, but assuming that she is relatively close to her family, I think you would want to encourage her to share that information about her wishes with them, even though you don't have an obligation or a duty or anything to disclose that information to family members. As far as this confession about the paternity of the child, no obligation there to share that information. Again, there's an interesting question about, suppose there's some genetic health risks in the family. It's kind of one of the new frontiers around the disclosure of medical information. What to do when medical information is not exclusively relevant to individuals, but also relevant to those who are genetically related. It's the sort of thing that we have a Master of Health Ethics program here at Memorial in the Faculty of Medicine. That's the sort of issue that I would get a a master's student to write a thesis about, because the ideas around it are developing in interesting ways. So, yeah, that's all I have to offer on this case.
Just a few other points. When we talk about the health professional, in particular nursing and social work, being involved in MAID, one of the things we do offer in our practice is a debriefing after, and I think that that's really important for health professionals to know, and I'm looking at Debbie Squires over there, who's been very involved in that. But I also think that the research shows, even if you don't supposedly have any reasons to not be involved in the MAID process, the research shows, regardless of whether you object or you agree, you still go through moral distress. So I think it's even more important for health professionals to seek some guidance and support from that perspective. The other thing too, I'd be curious as to why the woman was telling you, the health professional, about the son. Like, what's behind that? Why does she want to tell you? And is there, you might want to have a bit of a conversation about that, rather than just, thinking that, well, you don't have to tell anybody. So there might be something else that you can find out. And as Chris has said, there's a lot of genetics studies that are done now in the history, and it might all come out in the wash in the end anyway. But so that I'd be really curious about that. And I just think, leaning on the team to get some support from the team, not being alone in this kind of situation is really important.
Okay. This one was a bit of a doozy for me, for a number of reasons, and maybe not necessarily the reasons that are most evident, but the thing that had struck me was the cultural considerations and the conflict between the family's religion and the individual. And we talk about self-determination, and really, we talk a lot about freedom of religion, but we also have to remember freedom from religion. So when a person would like autonomy to self-determine kind of their end-of-life care and whether or not to participate in medical assistance in dying, that's an interesting perspective. And I have to say, I felt kind of torn about how to proceed, but I went back to value 4 in the CISW Code of Ethics, integrity and professional practice. Social workers strive for impartiality in their professional practice and refrain from imposing their personal values, views, and preferences on the clients. And when I think about a kind of exercising power in that discussion, so I'm not sure if I would venture into the land of the costs and benefits of letting the family know and not letting the family know, where this person has been clear that they do not want them to participate. In terms of the documentation around the disclosure, well, I guess the other thing that I would look at is her need to confess. And I would ask her, despite the fact that she's not acting fully on the family's religious views, would she like to have access to pastoral care to be able to talk about the issue about her son, and is that actually some kind of spiritual confession that she'd like to engage in? And the other thing is, we can look to the CISW standards in page 9. Social workers maintain timely, accurate, and legible records of social work interventions for each client. Social work records contain all information that is clinically relevant and significant to the service delivery. So that has to be taken into consideration. As it was pointed out, it's not actually part of the health record. And then the question is it even relevant to the service delivery? And of course, then value 5, confidentiality and professional practice. Again, social workers only disclose confidential information to other parties, including family members, with the informed consent of clients. So, yeah, I think the thing that really struck me was the two kind of places where the family is, and this woman who is distanced herself from the family culture.
So that is our 3 case scenarios. How much time couple minutes. So we have a couple minutes now and 2 microphones. If anybody has questions from the audience, Anna has one there. And you can ask the panelists any clarifying questions that you may have.
Thanks so much. I really enjoyed that. My name is Anna Caddick Duffy. I'm with the Center for Nursing. I'm here with some students, and I'm just a couple of points I think that are really important to bring up in the first case study. I just wanted to give the panel an opportunity. You weren't implying that it's all in or nothing, correct? In terms of caring for this family. We're talking about the scenario where the neighbor comes and asks you for advice. I think it's really, really important to note that as a neighbor, you are under no obligation to be all in. And I'm saying this for the clarity of the students, right? This is kind of new to them. And one thing I think that was overlooked, there's a big difference between providing a service and providing further resources. For example, they would be, I think, in my view, and I would like to know what the panel thinks, especially the lawyer, I would think there's nothing wrong with saying, if this was me, I would definitely consult with my family doctor to let them know how these series of events have progressed in terms of having the fentanyl and that. There may be a need for Narcan in the house, that kind of thing. That is not the neighbor's decision to make. I would be, and I just want to make this clear for the students especially, I would be very careful of engaging with any kind of professional support. And I think the thing that disturbed me is when I started hearing the need for documentation. That's implying you're going to step right in there and act either as a social worker or nurse. I think you have to be really, really careful and know that there are other options. The other point, and this is my last point, is I think Ms. Pelly made the point that this might be a good opportunity for education in terms of the mom. One of the things that I think is really important to consider is this an optimal time for teaching? And that's something you'd have to assess, isn't it, in terms of the mother, someone who is at the end of a rope and in distress. I'm not sure that that may be the best time to go into things like ethical, certainly confidentiality, but I think one thing that was overlooked that's paramount is the idea of providing or suggesting further resources. I think that's paramount.
Anybody want to take the first response?
I'll just make a comment. If the practitioner in that circumstance did decide that they were going to provide intervention with that teenager, so take that person on.
Are you saying the neighbor?
No, I'm talking about the health professional.
According to that case scenario, it was the mother. Sorry, pardon me. I'm just looking at that case scenario. According to that case scenario, my understanding was it was the mother going to the neighbor who happens to be a professional, whether it's a social worker or a nurse. And I just wanted to make it clear, to the students, I don't think it's a great idea under any circumstances, if you're that nurse and neighbor, to provide professional support in that situation. I just wanted to clarify that with the panel. You weren't implying that as a neighbor, if you were a physician or a nurse or a social worker, that you would jump in. And the term I kept hearing over and over again was all-in mentality.
What I wanted to clarify
Sure.
was, we were given a range of responses, but if that neighbor who is a health professional decides that, yes, I am going to enter in and provide service to the teenager, I'm not saying they should.
I don't think that's a good place to start. Do you think that's a good idea?
Well, what I wanted to present is if the person decides to do that, if the practitioner decides to do that, then the standards of practice and the code of ethics and any other regulatory guidance documents or policies or guidelines apply.
That applies to anyone that provider is taking care of, regardless if it's their neighbor or not, correct?
Well, it applies to them, of course, yes, in any situation when they're providing professional services. The fact that they're providing it to a neighbor doesn't lessen the requirements to adhere to the standards or code.
Is that something you would promote as a panel?
I don't think it was being presented as promoting it, but giving the practitioner things that they would have to reflect on when they were making their decision whether or not they were going to do it. And as Simone, I think it was Simone, talked about professional boundaries. As registered nurses, the College of Registered Nurses has documentation, a document on the therapeutic client relationship that would address boundaries and would give the registered nurse things that they would have to consider in the relationships.
I just didn't want the students to perceive the panel as saying you're all in or
No, that wasn't meant in that way. But if the practitioner decides they are going to do it, then the standards and the code, apply. It doesn't change it, the fact that you're a neighbor.
Any of you engage in that kind of practice?
I personally think, I'm not a nurse or a social worker, but I personally think it's a bad idea. But providing resources is a good idea, yeah. So, good point, yeah.
And I talked about, yeah.
I know everybody here has life experiences, but I'm just really cautious for my students to know that it's not a great idea.
And I do think, I agree with you. I don't think it's a good idea to jump in necessarily, but you could be in a community where you're the only health professional, right? So you really have to understand the context of what's going on and understand what's available for the mother, for the daughter, in order to direct. And I think what I heard Michelle and others say, once you start down that, if you're a health professional, you have to realize what that means, and especially if you're in a small community where you have limited resources available.
And the type of care that would be provided, of course, would vary from nursing practice and social work practice. So just to go back to the guidelines for ethical practice for social workers under dual and multiple relationships. Dual and multiple relationships occur when social workers relate to clients in more than one relationship. While having contact with clients in different life situations is not inherently harmful, it is a responsibility of the social worker to evaluate the nature of the various contacts to determine whether the social worker, and then it goes on to say, social workers take care to evaluate the nature of the dual or multiple relationships to ensure the needs and the welfare of their clients are protected. Of course, when you are a mental health and addiction social worker in a small community in Labrador, you may end up intervening with your neighbor's children. And then, of course, context and boundaries and all those things would have to be taken into consideration.
That case scenario, there was nothing there was no assumption made you're the only one. Sure, we can talk about scenarios, but almost, I would say the majority of the time, there are other people that can help out. And I can't think of many scenarios where it would be a good idea to intervene as a professional in that particular situation. And I just wanted to really highlight that. I think it's paramount.
And I think these are really complex situations, and that each of the panelists give a perspective that if you do enter into a duty of care, then, you got to have the knowledge, skills, judgment, the ability to manage the outcomes. And
you need to play it forward. So if you're taking on that person as a professional and you get a call at 2 in the morning that hit an overdose, you need to prepare for that if you're going to take that on. And I think those are really important consequences to consider.
And then, like Simone said, there's that pause moment in time.
Yep,
Lots of times you
absolutely.
have, you don't have to make that split decision. There is some time to make decisions. But there's a couple more questions, but are we over? Okay, we're out of time. Okay, so in closing, the goal of today's education session was to enhance our understanding of our professional accountability and the legislative, regulatory, employer, and ethical considerations that healthcare providers face in the everyday, and that they must consider and reflect on when navigating these dilemmas that come up in everyday practice. Also, it was a means to let healthcare providers know what is out there with respect to who you can contact, what resources are available to you, what standards apply, and what models you can use and that exist to help support your professional decision-making. So thank you again to the panelists for their wonderful job. And thanks to everybody for showing up. Please take a second to fill out the evaluation forms and give us some feedback and some suggestions for next year's topic. And if you're a registered nurse practitioner, social worker, you can collect your continuing competence 2-hour sessions. I have some forms down here, and so does the college licensed practical nurses, and so does, Okay, so thank you all.